Translation?
Yes, I'm fine.
Thank you. So there will be some presentations which are in English in this session. So again, please make sure you have the headphones if you need to. So in this session, we're going to really until about lunchtime, looking at the strengthening and prevention and management of NCDs in the healthcare settings. And we have a series of presentations which will be reporting back on some of the projects that have been taking place within Ukraine and supporting this work. And a lot of this work has been focused on cardiovascular diseases, on screening for hypertension and for cancer and diabetes within the primary care setting. And I recognize some of you from the different trainings that we've been involved in over the last few years that the World Bank, Swiss and WHO have been working together. I won't go back. We'll introduce each speaker, I think, as we go along. But we also have a colleague from the World Bank, Dr. Tanya Dmitashenko, who's a practice manager for Europe and Central Asia, who's with us for a little while this morning. And she's going to take an opportunity just to share some of the work that the World Bank is doing in support of this area.
Very happy to be here. I should start by saying that despite my name, I'm not a Ukrainian. I'm Brazilian, but have some Ukrainian descent. I just wanted to say that the work that the bank is doing in support of the government's health reforms really fits in the context of broader work on investment in human capital. Studies that the bank has done shows that more developed countries, in more developed countries, human capital represents about 70% of a nation's total wealth, compared to only 3% for natural resources, for example. Whereas in low-income countries, human capital represents only 42% of a nation's total wealth. So we see there the importance of investing in human capital for the development of a nation. And in that regard, we've calculated a human capital index where we look at a child's full potential to reach its full productivity if it had full health and full education. And what we see when we look at the Ukraine is that it's ranked about 50 in the total ranking of nations, compared, for example, to 30 for Poland or 34 for Russia. The Human Capital Index in the Ukraine shows that a child born today is only likely to achieve about 65% of the productivity it would have enjoyed if it had full health and full education. And when we look at what are the bottlenecks in the Ukraine, we see that child survival is quite high. We see that children are not stunted. Very few children are stunted. But what we do see as a constraint is that life expectancy is below what it should be. So life expectancy is almost 10 years lower than it is in countries of comparable income, and that the principal reason for morbidity and early mortality is non-communicable diseases. So for us, investments in improving prevention and treatment for non-communicable diseases is critical for Ukraine to reach its full potential. So in that respect, we have been supporting the government in its health reforms through a health project that has a principal objective of supporting improvements in the quality of non-communicable diseases at the primary and secondary level. We've also been working under that project in close collaboration with WHO in supporting the public health program in the country, and building capacity of government counterparts to deliver their public health program, in promotion activities to prevent the risk factors for non-communicable diseases. We've also been working very closely with Swiss counterparts in the implementation of, for example, the telemedicine program, and in general in support for the health reforms in the country. So we're very pleased to be here and to be working in close collaboration both with WHO and our Swiss counterparts. Thank you.
Thank you very much. Is there a report which has the information that you've described that would be available to counterparts in Ukrainian and in English if they were interested? Yeah.
Sure. First, one of the reports I was citing is a World Bank publication called The Changing Wealth of Nations. It was published in 2018, and that's available on the World Bank website, as well as information on the Human Capital Project, and the Human Capital Index is also, this information is publicly available in the World Bank website.
Thank you. And we talked yesterday a little bit about how we increasingly make economic arguments. It sounds perhaps a bit weird because if you're a family doctor or family nurse, you've got a patient in front of you who's got a disease, who needs help, or you're trying to prevent a disease. But also at the policy level, we're trying to make the case for greater investment in health and the work that you're doing. And so we switch between the individual patient and the macroeconomic arguments to try and help further the cause in terms of preventing and managing non-communicable diseases. So thank you very much. I know that also Feng Shao, I've forgotten your that you're working also in a number of countries that we're working on in similar projects. For example, in Moldova, we were there reporting on the work that's been done there. So thank you for your input and collaboration.
And if I could just add to that, I mentioned that under the World Bank project, the support to the government, we're working on public health, also in strengthening primary care, but I have also completed work in collaboration with the Swiss counterparts on a hospital master plan. So looking at sort of the whole continuum of care, and so that work is also, I think, critical to for the effective treatment of communicable diseases across the whole continuum.
Шановні колеги, дозвольте подякувати від вашого імені.
Dear colleagues, let me thank you on behalf of myself, on behalf of our colleagues, for your support of Ukrainian projects in healthcare reform as well. And let me mention that the data that you have just outlined, they are quite stressful, I would say, in terms of our statistics, even for such a well-informed audience like we have it here. So let me reiterate that our conference is quite a relevant event because the issues and questions we're going to discuss are quite relevant and topical. And now, under this given context, let me give the floor to deliver a presentation on improving NCD clinical practice in the WHO European region to Dr. Jill Farrington. Please, Jill, the floor is yours.
Okay. Thank you very much. I was asked to make a sort of introductory lecture, presentation about the sort of frameworks for some of the things which we will touch upon in the project reports. Why have we set up these projects the way that we have? How do we think that we can bring about a change and improvement in the clinical practice? But I've also been asked to refer back to some of the broader work on strengthening health systems, about the distribution of tasks between doctors and nurses, the teamwork, and some of the monitoring mechanisms that we use. So I will try to cover this broad selection of things. I will also try and change the slide. Okay. We saw this slide yesterday, I think, and it's just trying to keep a focus on what are we trying to achieve. We're trying to reduce early deaths from these 4 non-communicable diseases, and we also have a set of global targets on non-communicable diseases. And for our work in health settings, in clinical prevention, we're particularly focused on the ones on the right of the slide. So around reducing hypertension, increasing the identification and management of people who are at high risk, and also about increasing the access to medicines. And we heard a lot yesterday about the work that Ukraine has been doing on access to medicines. But also in the clinical setting, we have an opportunity for public health, for health promotion, health counselling, and so we also can have an impact on some of those other ones around risk factors like tobacco, helping people to stop smoking, to eat more healthily, reduce salt in their diet, and so on. So your work is impacting on all of these targets to a greater or lesser extent. And as we said yesterday, we have a set of best buys. That was the phrase that was used. So WHO has identified a set of cost-effective and effective interventions. So these are this is a list of the most cost-effective ones. If you see again on the bottom right-hand side, they're particularly focused around cardiovascular disease and cancer, but we also have a set of effective ones around managing blood sugar control in diabetes, preventing complications, and so on. So to get the best outcomes, we want to make sure that we're implementing these at scale across the whole country within the primary healthcare system where it's a clinical intervention. We also mentioned yesterday the work that we've been doing to try and identify what are some of the barriers to achieving those outcomes. And WHO over the last few years has been carrying out a series of assessments within countries. Ukraine was not one of those countries, but I know there have been some in-depth assessments since we finished this work, which also give us insights to the situation in Ukraine. So for those 12 countries, we looked at how well they were implementing those best buys that I showed you, and what were some of the things in the health system which were preventing them doing that, but also what were some of the things which were going well, some of the opportunities or some of the strengths in their systems. And then we brought it together in an analysis and had a big conference last year. And Ukraine actually, Deputy Minister participated in a session there where we, with a series of experts, looked in some detail at the situation in Ukraine, and he reported back on some of the healthcare reforms that he was participating in. As Jarno said yesterday, we identified 9 particular barriers, but also 9 areas where we could strengthen the health system response. And these were in areas like the governance, public health services, primary healthcare. I have to put my glasses on to read them all. How the specialist services are organized, the human capacity, the health workforce, health financing, access to medicines, and information solutions, and then also about making the healthcare system more people-centered. And what we've called these are the sort of 9 cornerstones of a comprehensive and aligned response, because each of those are important, but they're also important about how they fit together. So it can be that we put in place incentives performance targets for family doctors, and we have economic incentives, but we might actually make the situation worse because we haven't thought through how are we going to measure those incentives. We don't have good information systems, or we're trying to get people to do more hypertension screening, but there's no access to medicines, or we're trying to do a cervical cancer screening, but there's no treatment specialist services in place. So we identify people and potentially do more harm than good. So all the parts of the system need to fit together in a more aligned way. And that's where we use this image of the different blocks building together into a tower that fits together and works well. I'm going to pick out a few of those which are particularly relevant to the projects that we're going to discuss today. So the first was around primary care, how we have to shift from just having a doctor or a doctor and a nurse, or just a nurse or feldsher in some countries, to trying to have a bigger group practice with multiple disciplines in place. Other non-doctors, perhaps social workers, nutritionists, physiotherapists, healthy lifestyles counsellors, for example, who know well the population they're serving, so that their work is appropriate to the community of registered patients, and that they are working together in a coordinated way and with the other healthcare providers, so that if somebody has a heart attack or stroke, they go into hospital, that they then come back to primary care and they're working together to prevent another heart attack or stroke. So that's a coordinated care between the healthcare providers in the support of the patient. We also need to have a health workforce that is fit for purpose, and we talked a bit about that yesterday. So we need to have an increased availability of health workers, but it's not just about quantity, it's also about making sure we have people with the right skills. And we talked yesterday about the real changes that chronic conditions can mean. And also as people age, having multiple conditions means that it may need a different way of working with patients. So we're not just training new workers, but we also need to use those workers more effectively and maybe more efficiently. So we're looking at what is it that the doctor's doing that only the doctor can do, and what is it that the nurse is doing, and what is it that the receptionist is doing, the manager is doing, and any other health workers within that practice. I remember when we were doing the training for trainers for the Swiss WHO project, and we refreshed how do you measure blood pressure. And the nurses were just as good as the doctors at measuring the blood pressure. But when we got to the end of the training, the nurses were actually quite frustrated. I remember it got very animated in the session, because they said, we can do all this, but we're not allowed to do all this. And we can, try and change that. We can see, as we look at what is the role of nurses within the European region, there are many things that nurses can do that they're perhaps not being allowed to do, which they can do as effectively or more effectively than the family doctors. This is a list of some of the broad range of contributions of nurses, but it's, many of these are relevant to non-communicable diseases and chronic conditions like patient education, supporting self-management, supporting compliance with medicines, helping people how do they take their medicines, helping them to develop a care plan and supporting them in using that, rehabilitation and support to people when they return from hospital, for example, after they've had a stroke, and so on. So many things that nurses can contribute on, but it may mean that there have to be changes in the regulations, in the standards, in the education, in the insurance that supports nurses. I was in Central Asia, in Kyrgyzstan last week, and we had a whole session on nurses and non-communicable diseases, and we had examples from the UK and Finland and Uzbekistan, and they had said that really it had taken them between sort of 2 and 20 years sort of development to get all the regulations and systems in place to enable nurses, for example, to prescribe medicines, to have clinics by themselves. Some things could be done shortly and some things took a bit longer, depending on some of the barriers and problems in the way. The other thing that's particularly relevant for the non-communicable diseases is around people-centred health services. So shifting from services that are focused on the provider, that are convenient for the institutions, the professionals, to having ones which are more focused on the patients. And we heard yesterday from the Deputy Minister about the change that they were trying to bring in Ukraine, to have a more consumerist approach, to allow people choice, to allow people to change doctors if they were not satisfied. And in a way, this was a revolution or evolution within the Ukrainian system. And then in the care of the patient, to shift from having this biomedical approach just focused on the disease to having one which is focused on the goals. What are we trying to achieve? And asking not what is the matter with you, but what matters to you. So what is valuable to the patient and how do we fit your diabetes care around that? Do you want to do sport? Okay, let's talk about that. Or do you have a busy day? How do we manage your medications to fit with that? But that can require quite a change in terms of communication. And again, I think when we were doing the training of trainers and we did the first pilot training, some of the communication skills were quite difficult to do, that sort of newer communication skills that we need to be able to communicate differently as healthcare providers, but we also need to help the patients communicate differently with us and tell us more about what they actually need. And sometimes it's not just about tools or techniques, but it's also about changing sort of skills and attitudes of patients and providers. This is an example that we were using in a session at a conference last year. This is from Denmark, and they were explaining how do they do patient-centered diabetes education. And they said the health educator, which might be the nurse, is at the center, but they're actually they call them the health educator juggler. They have many balls that they're juggling because they're trying to form different types of communication when they're having the encounter with the patient. So they're trying to be empathetic, the embracer. They're trying to be reassuring and positive. They're trying to be inspiring, to inspire them and motivate to change behaviors. They may call the translator. They're trying to translate some of the medical terms or knowledge into words that the patient can understand. And they're the facilitator. They're kind of trying to manage the process. So they have many roles within one encounter. Just to give an idea of how complex it can be if we're really trying to take a patient-centered approach. Within the European region, we've got a number of projects where we are within countries where we've been trying to change clinical practice and the ways that we're doing things at the primary care level. I think 3 of these have been co-funded by the Swiss development group. I think in Moldova we had the equivalent conference 2 weeks ago, and we reported back on their findings. And we also have a project ongoing in Kyrgyzstan. And we have been using in those countries the WHO simple protocols. So again, you've done same thing in Ukraine, where there's been a simple protocol that's been created based on the WHO PEN tools. What we have found in those countries, and also from the literature, are that there are barriers to implementing evidence-based approaches, and these can be a range of for a range of different reasons. So it might be that the actual evidence-based practice, the innovation that we bring in, is difficult to understand. It's not attractive. So if we think of the example with Ukraine, they tried to make the protocols attractive, simple to follow, accessible. So you had a version that was available on the desk to try and break down some of those barriers to make them easier to understand and feasible to use in a daily practice. There can also be barriers around the professional themselves. We talked about the importance of the knowledge, the skills, the attitudes, and the training programs tried to work on those issues. But there also can be about motivation to change. So once the doctor or nurse went back to their clinic, were they motivated to change their practice and to put into practice what they had learned on the training course, and to change the routines, the ways that they did things. The beneficiary, the patient, as we said, may need to also change to learn new ways of communicating, or new things they need to comply with. Often in these countries on these projects, we find that initially there's a great increase in workload for the doctor or nurse as they're trying to manage these new tools, fit them into their normal routine. And they say, and then the patients outside, the waiting room grows as the patients are waiting. So then the patient comes in and they're angry that they've been waiting for 15 minutes instead of 5 minutes. And then I start asking them whether they are smoking, and they ask why. So it can also be a negotiation between doctor and patient, or nurse and patient, to transform understanding of and value of prevention and health promotion. And then there's the sort of barriers within the broader context, and some of those I've talked about in the health systems, barriers about access to medicines and so on, the financing, numbers of staff and so on. If I just go through some of the things which we've again picked out from the evidence and then tried to use within this project, some of the proven interventions which can improve knowledge. So, for example, education materials have an effect on clinical practice, particularly if they're combined with other methods. So within the training sessions, we provided educational materials and things for you to take away with you. Educational materials are more effective if they're active rather than passive and more small scale. So when we started this project, we changed the nature of the training program from being very driven by lectures to being smaller groups and more interactive in the training. Interventions that promote social influence. So, for example, having visits, connections, visiting the workplace regularly can have a small impact on practice, and involving respected local colleagues, local opinion leaders. So again, with this project, we tried to change the trainings so that family doctors and nurses were training family doctors and nurses, and that was a bit of a revolution at the time, and to try to have family doctors and nurses who could be leaders for other family doctors and nurses. They knew the world that you were working in. And then tailored reminders, decision support systems are effective in changing behaviours. So again, as I mentioned, we had the laminated cards that were available on the desk. We didn't have the option of the electronic records in all places. In this project, we didn't have financial incentives because the effect of financial incentives on performance is quite variable in terms of the evidence for effect, and it also was not an option. Audit and feedback also have small, moderate effects on professional practice. Anastasia will talk later about how much that was a part of this practice. I'm not sure if that was implemented in this project in Ukraine. In some of the other countries, we've had regular visits to every quarter doing audits of clinical records, discussing the results, tracking indicators, feeding back that information to the doctors and nurses so that they can see how their performance improved. I'm not sure that was an option within the last few years, but it may well be an option going forward. As I mentioned, we have a number of different projects, and what we've tried to do with each of these projects where we can is to monitor change and also to evaluate what has happened as a result, and then we're publishing and sharing that information. So you have got 2 presentations today which will specifically report on it for this project. And then what we've been doing, this is an example from Kyrgyzstan, is trying to put together the information that comes out of the quantitative analysis, that's in the center, the dark blue, with what we find from the qualitative, to try and understand what worked, why did it work, what didn't work, and so on, and then to again give that information back. I won't go into the detail of this. I'll leave this, you can get the slides in afterwards, because I can see I have 0 minutes left. But again, many of the things which we learned from this, we can then again go back to the evidence for how can we improve the way that we are implementing the guidelines. There's no minutes left, so I won't go into the detail. I'll just acknowledge some of my colleagues who've been involved in this work, and thank you.
Дякуємо.
Thank you. Thank you, Jill. Now, let me give the floor to the Healthcare Authority Director of Poltava Regional Administration, Viktor Lisak, who will present on the main challenges of controlling NCD at the primary level, and that includes teamwork, e-health, affordable medicines. First of all, dear colleagues, I apologize that I couldn't be present at the conference here yesterday. I had some urgent issues in Poltava, but first and foremost, I would like to say thanks to all the partners. I'd like to say thanks to everybody. And I would like to emphasize, let's look at this small curve of the changes that happen at the moment in the healthcare sector, and it's only the beginning. It's only the beginning of the changes that people need, that healthcare workers need. And yeah, healthcare workers might have some dissatisfaction, or they have some. Then they study the situation, then they look at it and they will accept, and it's a cycle, and the cycle of course is going on. So overall in the country, the transformation of the system, the changes, it requires a complex approach, and the main challenges in fighting NCDs at the primary level, well, we should not only talk about the primary level today, because the system is transformed on all the levels. And I thank to all the partners, to the Swiss agency, the World Bank, the WHO. When I was preparing this, when I looked at all the partnership, we wouldn't be able to do anything without the partners, neither at the national nor the local level. Because, as the colleague said, we need to re-educate people, we need to teach them the teamwork approach. And what happens now at the primary level, it's important for us. And, well, I'm a pediatrician, and so I have a first-hand experience. And in order to change the system, well, we had to start, of course, the primary level. If we look at this slide, we know that the state of Ukraine has taken a decision, and the partners know this, to change the system of payment for the primary care physicians. This is going on, but it is not only about the financial resource. We have to rework the whole process, from quantitative indicators getting to the qualitative indicators. And you see that Poltava, the region of Poltava, now is among the leaders. And if we look at how much resource we got, well, it was in 2013 when we've started delineating the primary and the secondary level. Because originally, even in 1998, there were first attempts to reform the primary level. And this is, of course, very important. But in order for it all to work, we need to train the staff. We really need to train the healthcare providers. And here I would like to say thanks to partners who have created this, and this is very important for us. We have created the network of these training classes, and this network is working now. And many colleagues who come from other regions who look at us, well, we have created basically the system of training all the specialists. They all will learn how to learn teamwork, not only the primary level, but also informational policy specialists from the specialists from other services. And this is also very important, because unless we train the colleagues, then practically we won't get anything. And today we have this regional training class, and there are practical sessions that are very important now to change the approaches and the tactics. Not just, it's not only the reshufflement of the financial resource, but we really can make the changes tangible for the patients. This is very important, and we do this comprehensively. We do this jointly with the World Bank project, jointly with the Swiss Development Agency project, and it's a comprehensive approach which is very important. Nobody believed in this program, and nobody believes, well, some people don't believe in it now. I remember one of the partners has set us the task. For example, you want to have a program for the patients with hypertension, but calculate, will you have the costs? Will you have the funds? Because you had the reimbursement program, and then it was cancelled, and then we took the statistics. Can people afford these medicines? So we were sitting for several hours and we tried to calculate, if now we do the screening, if we start working with patients at the primary level, can we do this? And yes, we can. And even our households will find it affordable. But of course, the specialists now shouldn't be dependent from the pharma companies, and this is very important. Yesterday I was coming here and the journalists were asking me, oh, we need this medicine and that medicine, and I call a specialist, is it available on the affordable medicines program? And they say, yes, it's possible. So we can do it. But who, for example, thought that the so-called e-prescription system would work? In the affordable medicines program, the e-prescription is working already. This is important. I won't even mention the training programs at the primary level, because the project has all the merits on this. And actually my colleagues said that I lost a little bit of weight recently, and basically I use this table. And I can give an example. There is a phone call from the Canadian representatives. They want to come to one of the primary clinics in our region to look at how the World Bank project is done, how we transform the primary level. And also Ms. Suprun is coming, there's a delegation, they come in, and there is a healthcare provider at the primary level, and he's using this table presenting what has happened in the system. And this is very important. We understand today, like last week, Ms. Elena was there when the aspects conducted a survey, sociological survey, and yeah, we don't understand some things yet, but still we have started this, and we are treading the path when the system is being transformed, and it's important. I won't read you all other slides, you all know this stuff, and just the main thing I would like to show, you know what, when we've delineated the primary and the secondary level, there was a question: how can we help people change the system? How can we make primary level work? So when we are preparing a project with the World Bank, with the partners, and we have a lot of them, and we appreciate their support, we've started with simple things. The experts told me, Victor, why do you want to have such a large project? Pick a small district, work it there. I say we have to have a comprehensive approach. From simple, elementary things. It's a headache for us today, but we've took this path. And we took it from simple elementary things. This is only the beginning. We could give it to people to show that things are going on, that some things are changed. Well, we don't have vacuum timers here, and it of course was a problem of the deliveries of the bio samples, but we could show that this is possible.
And I have one thing that I really memorized very well when experts from Swiss project came to us and we had a meeting. There was an expert evaluation or something like that. I just dropped in and there was a question, and a nurse who worked for 10 years in England, she came back and she said that the vacuum timers procured were not very proper ones and something like that. And she said, like, the more we train, the more we communicate, the better it will be. But what actually happened is that we managed really to show to the people how much has been done. Very simple things. And before, at the PhD level, because now we speak about very comprehensive approach in terms of prevention and etc., before, people would have to wait to be tested for controlled arterial blood pressure measurements. People would have really to wait for 3 to 4 months before they would get those measurements to get their disability category. Now, the change is that every family physician now has all this equipment at his disposal, and that is quite important because it has been done all over the territory of the oblast. But we had to train our staff how to do that, how to make use of it. And as of today, dear colleagues, dear friends, dear colleagues from international level, you are our partners. Without your support, from the support from WHO, the World Bank, we could never be able to do that. But these are really very simple things, though very important. In Poltava region, we performed a really unique pilot within the World Bank project. We all know that when an individual comes with test results from outpatient clinic or family medicine clinic, nobody usually trusts the test results. So we developed a standardized approach to that. Now all the test results are really similarly obtained in every region of the oblast. This is a very cost-effective solution to the problem at the PHC level. Because when you work as a team, we discussed how to do that for HIV, how to do that for TB, and now that was for the first time when we started teaching our teamwork approach at the PhD level under support of the WHO and the World Bank. Thank you very much, Miss Anastasia, by the way, for that, and we will definitely continue doing that. And colleagues, you remember, these are like the old things which might already be forgotten, but these are good practices, and I really saw that the people were very much satisfied with that approach. And when you go out, it looks like this is an outreach work. When you go out to people, you do collect the specimen for testing, you perform some blood pressure measurements, some other measurements. This is also a very important component of NCD preventive activities. If you look into Poltava Oblast, almost 500 settlements that do not have any healthcare worker, and they have to go something like 20-30 kilometer distance from their site. So we can have a kind of a mobile or outreach team that could go out to the settlements, and that has become a really important piece of a very comprehensive work as of today. And that all became possible due to support from our colleagues. I'm not going too deep into that because it was already someone already touched upon that. Mr. Fon, when he suggested us an idea, like you implement a big project, and we focused on 5 main pillars: emergency care, hospital regions, NCD, master plans. This is something that we are really focusing on. And if you look now into that cascade approach, this is what we can do, this is what we can analyze as of today. But this is a very good approach, actually, really to teach the people how to tackle the NCDs. When we started doing that, it was in Lviv and in our oblast, by the way. Now we're quite ready to show the results, to show the outcomes. But these are really the good approaches to hypertension, to diabetes mellitus type 2. And today, when we started analyzing the situation with those conditions, including breast cancer, cervical cancer, I will just briefly skip those slides, not focusing very much on that. But these outcomes, these findings really showed us what are the focuses, what are the points of our attention, a special attention that we need really to focus on as managers in the healthcare system. And speaking about communication, that is the topic which we call today to be really super great and super huge. We had to prove to the audit chamber why we developed a hypertension self-control register. We did develop it, it is really true, but we suggested that idea. It is not enough, definitely, but you can see, I will briefly leaf through these slides so that you could see some of them. And our colleagues say we do have quite enough of information and material collected, which enables us really to make decisions. So thank you very much, dear colleagues. Thank you very much for your support. It is very important really to be a good communicator, bringing this information to the public and understanding the proper ways how to resolve those issues and problems. Thank you very much. Thank you very much for that very positive report with very positive findings. I do really hope you will publish the report of your activities and with your analysis. We heard you have training centers available. You started to train your staff. We would really like to see how it impacted the health indicators and health determinants. Sorry, no microphone is used. No microphone is used, sorry. As of today, and that is a big mistake, I would say, in the country, that you want to reduce the disability rate and the mortality rate like today, right off the spot. You need to have proper indicators first. You are quite correct. Let's do it. Let's work on that. Let's work on indicators and the way we can impact those. Yes, thank you very much for that. And now a representative from the World Bank, Olena Doroshenko, with a report on cascade approach data for decision making. Now we can hear some findings, I guess. Well, thank you very much for an opportunity to deliver my presentation during the conference. These issues are quite important, and we are quite happy that we have substantial progress in improving accessibility to services. Thank you very much for your very positive feedback regarding everything that has been made and how much has been achieved together with our colleagues in cooperation with the WHO, the Swiss Cooperation, Development and Cooperation Agency. I will really share with you some findings. This is a kind of a component, a piece of work which we're working upon together with the regions and our colleagues. And some of the slides could already were presented. Some of them will be skipped, but I want to show you one of those that you already saw. Here we speak about an additional analysis format in order to understand how effective are we in achieving the targets, how effective are we in working with our patients, and what are the results. The cascade analysis is really important to understand the whole chain. There are 4 simple questions here. Is a patient diagnosed? Is a patient diagnosed, has a health condition? Is a patient linked to appropriate health care? If the patient monitored on the care regimen? And does the patient achieve disease control? Very simple questions, but there are good findings and there are some good results you will really have to work upon. Just for the sake of simplification, let me focus on a couple of slides. You might remember that slide from a previous day. It tells you that in Ukraine we have quite high level of risks with high blood pressure. As a result of that, unfortunately, quite many people die, or people have a hypertension condition. They might get the disability condition and they lose their productivity. If we compare this data to the developed countries of the world, we have some good models for action. Because in Ukraine, the mortality following the preventable diseases is still pretty high, and we are yet working upon challenges which have already been overcome and have been already resolved by many other countries. And that means we still have a good, let's say, room for perfection, and we can improve really the health of our friends, relatives, and the people you come across on a daily basis. I think it is worth saying that the cascade method was used in the beginning for chronic diseases like TB and the HIV infection. But the method is very demonstrative, very illustrative, I would say. So we decided really to make the following step and understand how it can be used in regard to other conditions. And the previous speaker already mentioned these 4 conditions: hypertension, diabetes, breast cancer, and cervical cancer. And I would like to speak a bit about the findings, well, not maybe that much of the findings, actually, which are quite important, I would say, for further activities at the level of project planning for us and for you at the level of managing such patients and managing your projects, improving communication with your patients. When you speak about hypertension, and I think this is one of the most prevalent conditions in Ukraine that we come across on a daily basis, we have here 2 cascades that illustrate the situation in Lviv and Poltava Oblast. And these columns In Ukrainian version, it might be a better explanation. It explains what happens to a patient at different stages. So it basically gives the estimated number of hypertension patients, how many people know about their problem with health, how many of them know their diagnosis, how many of them have a regular monitoring, which means they present regularly themselves to a doctor, and the doctor knows what is happening to the patient. And also, from the point of view of way of life, treatment efficacy, how many of them achieve the controlled level of blood pressure, and how many and to what extent we can associate with that number of patients with the number of hospitalizations, admissions to hospital, as well as their life expectancy and their healthy condition. You see, these columns are quite different in size. That means we have quite many losses, and they are most substantial at some stages. You might see it here. There is a big gap between the light green and the gray column, which means regardless of the number of diagnosed patients with hypertension, there is a problem really to ensure regular monitoring for these patients. Especially this is true for the most complicated conditions for whom it is not really easy to achieve the controlled level of blood pressure. You know, there are clinical guidelines that recommend really more often monitoring for those patients who cannot achieve 140 to 90 figures. And that means such patients require more attention. But usually what happens is that these patients stay out of sight of healthcare professionals. They either do not want to go to hospital, or it is not easy to negotiate with them really to make them take their pills properly and come on follow-up visits. And thus we basically lose quite an important group of patients. And this group is not properly followed, is not properly monitored, and that is the group that really leads to the highest number of hospitalizations, and this is the group of patients that is really suffering from the highest level of threat for losing their health and high mortality rate. Column number 2, you can see there is a big difference between the controlled treatment and monitoring, and there is quite a substantial gap there as well, which means if you follow up your patients and they do actually present themselves to a doctor in some regular period of time, the problem here would be really to ensure controlled blood pressure level, regardless of the fact that the accessibility to medicines is quite good now as of today. The situation has improved. Some patients are quite diligent, I would say, but still something is going wrong still there. And you can see that, you can see it on the basis of this very demonstrative data. We have collected that statistical data. We have worked upon many records. And if you take that that cascade approach and you basically filter the patients during each of the next stages, you can say that only 5 to 6% are fully fledgedly being monitored, followed up, and really achieve the controlled level of blood pressure, which is a very low figure, I would say. I will not go too much into details regarding other conditions, but we know that hypertension is really associated with a large number of hospital admissions, and as of today, this is quite a huge number of patients that we have in hospitals who are treated against hypertension. And we see that the number that these cases might be prevented, because the people who are admitted, they actually were supposed already to be on the radar of a family doctor. Because usually these are the patients that would have high blood pressure for a long period of time. They would have some concomitant conditions. They would have overweight problem, They are quite elderly people, and they would really require more attentive support. So if they were paid more attention at the PHC level, we could be able really to support the healthcare system better, saving more resources to be reallocated to more aggravated cases, acute cases, and definitely we can prevent patients being admitted in a crisis situation that could easily be prevented. I will skip a couple of conclusions here. I think you will be able really to read them very easily yourself in your on your USBs. And still, there is one issue you need to really focus your attention on. When we mentioned we worked with many records, patient records, what we saw is that not enough time is paid by the doctors to the risk factors. And quite often the case, we don't have any information if this is a smoker patient. What is the weight of a patient? Are there any changes in weight? And Anastasia will show you these really measuring strips soon. And our colleagues know from the regions how much time we have been fighting really with the physicians at the PHC level really to make sure that they have these very complicated equipment available. But these are really simple things that really save lives. This is kind of a promo slogan.
Just for comparison, let me mention another disease, the diabetes. And this is a problem that often is concomitant with hypertension. So managing both conditions is important. Just pay attention to this cascade, and later you'll be able to have a longer look on this. This is the cascade from Lviv and Poltava. You see that the columns lose a lot of patients at every stage. If you break down all the cycle of care, such as following the patients up, checking if the glycated hemoglobin is in the norm, and you see that the patients who are followed up in Poltava, they have access to glycated hemoglobin, and which is a good resource for the diagnostics, but still they don't achieve the indicator. And this was quite a surprise for us, that in the system there is a significant resource, and you spend a lot of time to talk to patients, to prescribe treatment, to write new recipes, to refer them to the endocrinologists, and then for lab tests. And I wouldn't want to say that this all is in vain, but we should know that quite often all these efforts do not lead to the result, which is having the controlled sugar level in blood. And another thing, we've looked at the ABC diagnostics for the cholesterol and glycated hemoglobin and the pressure. And the patients with diabetes quite often have no notes about these parameters, and this is a problem as such. And also that comprehensive attention is not paid to this, because such a patient needs to be also followed up comprehensively, and the patient must be aware of all the issues related to their condition and how they can influence them through lifestyle changes or treatment. Good. I think, well, I have a minute, right? On breast cancer. Here, I think the conclusions are more or less the same, but what's important here on breast cancer, we understand that the screening program is not set up everywhere. Oh, 15 minutes again. Anyway, in Lviv Oblast, for example, there is the possibility to take the screening, but the invitation system is not worked out yet. The patients do not get invited for rescreening on time. Like, there are issues overall in Ukraine, but even when we have the capacity, or even when we have a certain bias, quite often the gynecologists, they see same women who go for regular checkups, and this is about a half of women. Another half of women probably cares about their health less. They see doctors less often, and they never are in the scope of their attention until they have a complicated case or a later stage of cancer. This is a huge loss for the healthcare system, because if we find later stages, then of course the treatment is more like, well, the extension of life is not that long. So how do we change the system? How do we detect the diseases at earlier stages? How do we change the lifestyle in patients who could do it? This is still the challenge that needs to be addressed. And I will not go into this. You can look at this slide. If you haven't heard about this before, it might be interesting for you. There was just one more thing that is not really about prevention, because we've talked about prevention a lot. This is about treatment. And here, once again, there are nuances. This is by cervical cancer stages in 2 oblasts. Poltava is on the right and Lviv is on the left. You see, it's written down there. You see also the legend, the breakdown by type of treatment, and you see how, and you see the variation. And once again, it sets a lot of questions. Do we have standardized treatment? Can we provide standardized treatment? Yeah, but anyway, it influences the result. And this is what we think should be noticed. Because even if we say that, okay, this is treated in the oncology hospitals and this is their thing, but once again, these patients then come back to you, to the family doctors who really take care to extend the life of the patients for the next 5 or 10 years. And we don't really know the survival rate for the patients with oncology diseases here. And all these tiny details, then they add up to this huge set of NCDs, which is the subject of the conference. Well, I probably will stop here, although I have one more interesting slide, but you can find it if you look at the slides.
And I understand that you are also writing that up as a report that people can access?
Так, у нас є...
Yes, we have a brief, policy brief. So, a brief document that outlines all 4 diseases and all challenges identified. You have them on the pen drives, and the slides are there on the pen drives. And the bigger report is being prepared now. There will be more detailed recommendations on what should be done.
And I think the presentations fitted well together, where we have our director from Poltava talking about the importance of information.
Фон мені підказує, що ці звіти всі ще є.
Oh, actually, they told me that all these briefs are also published published online at the World Bank project site.
Useful is if we put those on the slide at the end, so the ones that you mentioned, so that we have all those web links together. It might be useful. It would be easy for us to put up because I don't have those. Thank you very much. I'm conscious that we have 2 more speakers before coffee. Can we just stand up and just kind of move in our seats? I'm not going to do this with everybody, although my colleague is there waiting for me. But can you just stand up, move around a little bit whilst Anastasia, otherwise we will have no energy. So we introduce, I think you all know, Anastasia Dumcheva, National Professional Officer in the WHO Country Office. If you want to stand during the presentation, as long as you're not blocking, feel free to do so. I did that yesterday. I took time to go and stand at the back because I find sitting for a long time quite exhausting. So if you want to stand at the back or move on the spot at the back, feel free. I'm sure it will fit well with her presentation. So Anastasia, the floor is yours.
Доброго ранку, колеги. Рада вас бачити сьогодні.
Good morning, dear colleagues. It's a pleasure to welcome you all here. And my task here today is to remind all of us what is the path that we've taken with this joint project by the MoES, WHO, on NCDs, Prevention and Health Promotion in Ukraine, supported by the Swiss Development and Cooperation Agency. We have taken quite a serious path. We've done a lot, and when I was preparing the presentation, I was trying to remember all the things we've done, and I looked at all the stages starting from 2015, and I divided them into three main phases: the preparation phase, as part of the project, the implementation phase, when we've started implementing our events in the oblasts, and another also important part was the evaluation phase for our results. I only want to remind you about what was done. After the presentation, there will be additional presentations by the colleagues who helped us conduct this and analyze the data. So, the preparation phase. Let me remind you about the purpose of this project, the project by the Swiss Development and Cooperation Agency. The goal was to improve the capacity of the primary level to provide services, to prevent, timely diagnose, effectively manage and support patients with NCDs, with the focus on cardiovascular diseases. Why did we have this focus? I would like to remind you, and you probably have heard about it, and you probably have seen different graphs and visualizations, but I think here, on this slide, we can clearly see the share of the NCDs to all the daily years. The daily means years of lives adjusted for the disease rate and mortality, and you see how many daily years are caused by NCDs. So this shows that the primary care providers, they have more patients with these issues than with others. So the fact that you are busy every day is because you see many patients with this pathology. Oh, sorry, there's some lag when I click and change the slides. I try to learn how to use the clicker. So this graph once again shows why in our project the focus was on cardiovascular pathologies, because in Ukraine we have one of the highest premature mortality rates in Europe from cardiovascular disease, which is 4 times higher than in the EU countries. You can see it on the chart. The red line shows the indicator for Ukraine. The green line shows the indicator for the EU. And what really is worrying for us, this is the early mortality of men, which is 3 times higher than in women. The next slide shows our pilot regions. This component of the project, which we are talking about now, we've implemented it in our 7 pilot oblasts in Lviv, Ivano-Frankivsk, Vinnytsia, Poltava, Kharkiv, Dnipropetrovsk Oblast, and the city of Kyiv. When we've been preparing this project and planning the interventions, we have looked at how many primary level providers do we have in these regions? You see the figure, about 20,000 professionals. So that includes family doctors, nurses, and junior providers that work in the district. So we had to train at least 50%, which is basically 10,000 people. So we understood from the beginning that we have to train 10,000 people, which was quite a challenge, honestly. And we've started thinking, what can be done? How are we going to do this? How can we do this in the most effective way? What we've started with, it was with the support of the WHO Europe and our cooperation center, for example, the Finnish cooperation center, and with other experts, we've prepared a training course that is what's called Essential Training for Primary Healthcare Workers on the Integrated Management on Hypertension and Diabetes. What was special in this training? Once again, we've analyzed that people who are working at the primary care level already know things, and we don't want to tell them what they already know. So the goal was to use evidence-based approach to teach the primary care workers those things that they definitely don't know and that are going to be useful and effective for their patients. The first thing we've understood we have to do is that we have to teach healthcare providers, doctors and nurses together. We have to train teams so that they would have shared understanding in order to achieve the shared goal. Also, this helped during the trainings. This helped trying to find solutions to redistribute their functions, because effective management of NCDs would involve these specific changes in the functions of who does what. When the nurse and the doctors really start working together, they have a more synergetic approach when they redistribute the functions. Also, as they were training together and they started thinking of how to make their work more effective, they also thought what is required in terms of reorganization of their working conditions. We understand that there are limitations. We understand that some things couldn't be changed on some sides, but at least it was a first step to give new ideas, so that then later maybe they could inform the authorities, so that something could at least be tried locally. So, changes in the patient management. What was the innovation in the training? We focused on assessing the total cardiovascular risk. And for many of our participants, it was not part of common sense, because doctors are used to treat as soon as the patient has any complaint. But here we start explaining that you have to assess the cardiovascular risk overall, and that you should use certain criteria, even when the patient has no complaint yet over cardiovascular system or any other system. Also, timely detection of the risk factors on NCDs, regardless of the diagnosis yet, and really working with the primary care to reduce the risk factors. Then, treatment depending on the risk of CVD, well, it was not that of the innovative approach, but still the doctors understood that the patient management would depend on the risk. Also, integrated management of hypertension and diabetes, we've also focused on this a lot in the training. And Another component was integrated in the training sessions is how to work with the patient, so that the patient would be able to provide self-care. Here, I would like to focus once again that working with NCD risk factors through short interventions, through the advices, through trying to reduce the behavioral risks, they all were in the scope of the training, and also motivational counseling. We've included this in the training sessions, and the feedback was very, very good after people started using this technique. For almost all the participants in the training, this was a new thing. They had never, ever heard about this in the previous medical training. So the motivational counseling was a really key component in our trainings. And yeah, the behavioral risk factors, you see them on the screen. We've talked about this, and we've told the providers how to work with the patients, how to motivate them to reduce these behavioral factors. Other useful interventions. Besides the content of the training, we've also created this tool that helps clinical decision making. We've laminated this tool and put them on the table of every doctor and nurse, so that they would be available for a long time, so that they would be handy, and so that they would be actually used in practice. And you have them in your folders. If you haven't seen this before, please feel free to take a look. And also we've developed this very nice measurement tape. You might have seen it yesterday already. You see, it has colors. Basically, we took the idea from Finland. When we were in Finland for a workshop on NCDs, we've seen a similar, they did it a bit differently. It was a similar measurement tape, and we took this idea from there, and then we were giving out these measurement tapes on the training session, so that at primary level the nurses and doctors would be able to use them.
And the next stage would be the implementation phase. Let me note here that we really cooperated close with the Oblast health departments. I'm really grateful to all of them, all the experts from Oblast level who were involved into our activities and into interventions planning. Here, on the next slide, I just decided to add a couple of photos for you to see that we did visit every oblast, that we did have a meeting with like all partners in the oblasts, and we really discussed in a joint manner what would be the most effective and the most efficacious approach really to implement those activities and interventions in the sites. We did that jointly with our colleagues from World Bank, who have been working in 4 oblasts, and out of 7 oblasts, 4 have been, and they are still, the oblast where the World Bank is very active. We would also invite experts from the World Bank. We knew they were really very active in the field of NCD control, so we really coordinated our activity to make sure we do not have any overlaps, and we would be able really to make use of resources the most effective way. So let me reiterate really my gratitude to everyone who was involved. Planning was a very serious piece of work. It was not very easy, I must tell you, because teaching and training so many people in a very limited period of time really required very exhaustive efforts, I would say, and there were definitely peculiarities in all regions, and we managed really to approximate, let's say, to bring the trainers and trainings as close to the sites as possible. We would usually pick a district center, which would be quite a good place to come for the majority of districts around, and then the plans would be approved by the Oblast departments of health. Well,
Після того, як ми це зробили, ми підготували...
Right after that, we also trained the trainers. The number of trainers was calculated on the basis of already developed Oblast plans. We had first to develop the plan, understand how many people would go where and how many trainers would be required for that. 2 or 3 TOTs were conducted. We trained 52 Oblast-level trainers from the pilot Oblasts. You see here it was 2016. And then they started really to do their cascade of training. We also cooperated very actively with the medical chairs and departments of the medical universities and colleges so that they could be able really to integrate components of those trainings into their training curriculum. And the outcomes, following the number of trainings and number of people trained in cascades, we have conducted 2-day trainings implemented in 7 pilot regions. We never allowed more than 30 participants per training session, otherwise it would negatively impact the quality. We have conducted around 400 training sessions in those 7 oblasts during these 2 years, and we have trained more than 10,000 PHC healthcare professionals, which equals to about 55% coverage of the total healthcare staff. And here, this is a kind of a summary table, and there below in red color, this is the total number of people trained, and here this is a visual demonstration of what actually happened in every oblast. I must tell you, the progress was quite different in different oblasts. In some of them, we trained more physicians. In some other oblasts, we trained more nurses than physicians. But in general, all oblasts but one have achieved the target indicator of 55%. What was done next? Definitely conducting trainings was good enough, but what else had to be done following that? We got the feedback forms, we have analyzed them, evaluation forms after the trainings, and according to the feedbacks collected, we really updated and revised our training sessions based on the feedback from our participants, and in compliance with the ongoing reform, we have implemented some changes to those. Now we are working jointly with the World Bank, developing an online training that would be accessible to everyone who would like to have it in the online mode. And the most important thing, we also conducted analysis of feedback from teachers of postgraduate departments of medical universities and colleagues who completed this training. And my colleagues, I guess later today, will tell us how interesting, to what extent it was interesting really to the faculty staff, and we really looked into the changes that really took place at the PhD level after the nurses and healthcare staff, physicians, were trained during our trainings. There will be a presentation from Professor Tiina Latikainen from Collaborative Center in Finland, and also our partner organization that really assisted us in data collection and analysis from the Institute for Public Health Policies. Thank you everyone who participated in this work with us, who supported us. I'm really
регіональному офісу.
I'm really grateful to the WHO regional office in Europe, for Europe, Jill Farrington, namely, because it all happened under your very high-level expert support. I'm grateful to our national experts and trainers, grateful to our colleagues from the World Bank, the Oblast departments of health. 7 plus 3 means 7 pilot oblasts plus 3 additional sites from which we had a chance to collect data. I'm also grateful to our regional coordinators and definitely our regional trainers. Thank you everyone. Thank you very much everyone. Thank you for this cooperation.
So much. I'd forgotten what a long journey it was. It started in 2015 and we've been around all of those years. We propose to take a coffee break now because it's due at about 10:30 and then we will continue with the presentations. As moderators, we're aware there are many presentations but we do want time for questions and answers. So can we suggest we just take about 15 minutes for coffee and then come back in and we continue? Take the opportunity to keep moving and we see you soon. Thank you.
Thank you.
education, and she's going to explain about the integration of the NCD training into postgraduate education.
Шановні колеги, ще раз доброго дня. Мені дуже приємно.
Dear colleagues, good morning again. It is really my real pleasure to see familiar faces, and it is really my pleasure to continue this today's trend, talking about positive examples, positive best practices, I would say, available not only at the global level, in the field of NCD control, but also available in Ukraine. Being a faculty staff, definitely I would like to speak about some global trends in the field of training the primary care workers and the mid-level medical staff on the integrated management of NCD cases. This is what Anastasia has been talking about. We have conducted trainings in 7 regions of Ukraine, and in the end of recent year we have conducted a kind of questionnaire or survey among the trained staff on how they implemented those new approaches that they have been trained for. We had 25 teachers and medical workers from 7 regions of Ukraine involved in that nurses and doctors education. There were 5 doctors of medical science, and they provided their feedback, and they were quite similar, I would say. So our responders were teachers and trainers involved into training general practitioners, family doctors, as well as nurses. Part of them worked both at the pre-diploma and postgraduate training, and they trained both physicians and nurses. What were their specialties? These were specialties that under their competences would be involved into risk factors finding, correction and management of patients with NCDs and chronic diseases. And this is both true for internal medicine, as we call it, or family physicians. These were the questions included into the survey. These are the questions regarding personal data. There was some data regarding the evaluation of the training components and some recommendations as well. So what were the responses that we got? They really made us very happy, and we want to share it with you. 100% of people said it was a very useful training for them, for their professional activity. And it is also necessary to note that regardless of their level of training, let it be the head of chair or head of department or their assistants, majority of responders mentioned that they really got lots of novelties and really very new pieces of information, though it was quite a basic training, I would say. What topics were new for them? This is what Anastasia mentioned about. That was a motivational interview. 21% of responders replied like that. That is very important because it really indicates us about the gaps in their training, even for the highest level faculty staff. Quite interesting aspects in terms of clinical work with NCDs. This is true for PAN tool from WHO. 10% of people who are quite positive about that issue, that question, they indicated also the methodological aspects of training. That was something that they liked very much. So they liked it very much in terms of methodology. They're going to use it in their activity. Methodology in terms of presentation, development and preparation. So basically we managed really to deliver this information even to the most highly trained experts. 1/3 of people said that the most valuable information for them was information about clinical component, which is management of patients with hypertension and diabetes, and some more topics were indicated, and the top 3 here was also motivational interview component. Regardless of the fact that we have not been taught to do it in my medical school, even when I was in on the highest level of my training. I didn't receive anything like that, like pedagogics training, etc. And this is exactly what it showed was also true for the majority of our responders. What information we could add really to improve the training even more. So we asked what kind of information could be added to the workshop to make it even more valuable, and we got the following answers. Apart from the fact that the part of people said that all the necessary information was adequately resembled, which means that was quite an adequate approach to the amount of information, amount of new information, importance of this information to their teaching practice. And about 14% of respondents mentioned they would like to add an issue regarding non-specific chronic pulmonary diseases, which is a good actually topic attributable to NCD. And we do realize, though, that in order to add one more condition, it really will take another piece of time for us. It will really enlarge and make the training workshop be more extensive, so to say, be more lengthy. There were also some issues that they wanted really to include on metabolic syndrome, emergency care. Part of people would be interested in alternative methods of treatment. But we decided to focus on the fact that we're going to make use only of evidence-based medicine, and all kinds of alternative treatment methods need to be trained elsewhere. And speaking of expansion of methodology block, this is very important. So basically the teachers, the faculty staff asked us to teach better. What we found also is that we got some information regarding the implementation of the training materials into the teaching practice, which is basically their direct responsibility on a daily basis. Overall, it was very positive when we asked, do you make use of these materials in your daily practice? 100% of respondents said yes. No one said no. But the use of those training materials was partial in 20% of people would use these distributed materials. About 20% of them would make use of theoretical, didactic part of the training, and about 45 to 50% used all materials from the training. We also wanted to learn if our faculty staff managed to adopt officially any training agenda or training syllabus with the use of components or fully of the training workshop. And that was really a nice thing to hear, that up to 50% of faculty staff working with family physicians and nurses at the postgraduate education level managed to approve these trainings as a cycle of their continuous medical education cycle. And that was very important, I would say. That was a very important step forward that would facilitate the distribution and spreading of this information among healthcare professionals and nurses. Speaking of trained specialists, what we achieved actually, this is both true for physicians and nurses. We have good achievements for both specialties. This is the data that we got in 2017 and 2018, and this is a good result, I guess. So what are the conclusions? This training became a very useful tool to promote the further implementation of NCD-specific questions. It enables really to go on working within the existing curricula, but also enables really to approve the new ones. A further improvement of training can be implemented through widening of clinical problems, including different NCDs. Thank you very much.
Thank you. See how the training was used afterwards. Great. Should we keep moving so we have time for discussion? So if we move next to finding the results of the evaluation, if I introduce Professor Tiina Lahtikainen, who's the director of our WHO Collaborating Centre for Non-Communicable Diseases in Finland, based at the National Institute for Health and Welfare, is it? It keeps changing its name, but yeah, I think that's what it's called at the moment. So Tiina, the floor is yours.
Thank you, Jill, and dear audience. I have a pleasure to present you the first preliminary results of the evaluation of the project, what actually Anastasia very clearly explained to you already earlier. And I have to remind you that we actually got the data in April, so it has been quite a short period, and we are already in this phase that we can present, however, something. Could I get my slides, please? And the English ones. So I think the English ones will come soon as well, but maybe I'll start. So as explained, what has been done is that we did an evaluation survey to the 7 intervention regions and 3 control regions, evaluating the PEN implementation project, the training project here in Ukraine. And data we with the local WHO experts and the international experts kind of created the protocol and manual how the evaluation study is done. And the data was collected by the Ukrainian Institute on Public Health Policy. And the data collection happened now in the beginning of this year. So the protocols and plans were done during the last year, and the sampling was done last autumn, but the actual data collection happened this year. So there were altogether 7 intervention regions and 3 control regions from which the data was collected. And the data was collected from patient records, so the paper-based patient records, so that we collected data from pre-intervention period and post-intervention period, kind of having a marker day from which backwards the data collectors were collecting that information and variables we were interested in. And it happened between January and April this year. And the target population, patient population, were males who were aged 40 years or over, and females aged 50 years or over, which is also the target population to target, for example, the total risk assessment according to the PEN protocol. And these patients had to have to visit the medical facility during the last 12 months. And that was the eligibility criteria for the data collection. So when there were 7 large regions with having many, many rayons in them, the sampling frame was so that we randomly picked 4 rayons from each 7 regions. And from these 4 rayons, 20 doctors who were trained during the intervention. And of course, in the control regions, they were not trained. And then from each doctor, 24 patients, so that half of them were men and half of them were women. And we had a specially developed data collection tool, kind of indicating what variables we are interested in, like has the patient been diagnosed for hypertension? Can you find a blood pressure recording? Can you find a value for cholesterol, and so on? So these, here you can just see what were those intervention regions and control regions. And this table shows you how much data was finally collected. And I would like to pay your attention that there was a huge amount of data collected. So like altogether 4,000 observations, both for the baseline and follow-up. So actually 8,000 patient records went through during the data collection, which was a major work done by the Ukrainian Institute on Public Health Policy. And here you can see that the sampling procedure kind of worked pretty well. And the age and gender distribution, both in the control and intervention areas, were very similar. And so we can kind of think that the data what we have is reliable. To remind that really the purpose of this evaluation was to try to get information, has there happened changes in the intervention regions in terms of the processes of total risk assessment or the management of non-communicable diseases or the treatment outcomes. But also you have to remember that it's extremely interesting to see what is the overall performance, what is in overall happening in primary healthcare in Ukraine, because I believe such data doesn't exist before. So based on those different variables we have planned to collect, we kind of created predefined indicators that we were then supposed to calculate. I don't go these through because it takes forever to read this, but you will get this material so you can see what kind of indicators were. But however, we collected information on risk factors and the diagnosis levels, so how many patients had certain diagnoses, for example. We collected information on different process indicators, so whether certain risk factors were recorded, documented in the patient files. And according to and especially we were interested on those topics that were trained during the training in the intervention. And then we also assessed some outcome indicators among the whole patient population, but also separately for certain patient groups, because there was kind of enough data to also do some subgroup analysis for cardiovascular disease patients, hypertension patients, and diabetes patients. So some data here. This is about smoking, and smoking status recorded. In control regions, there was not a single recording of smoking status, not at the baseline, nor after the follow-up. So it seems that it's not the practice of recording the smoking status of patients to patient records at all. In intervention regions, there were some recordings already at baseline, so probably there are regions where there already has been certain activities going on, and there has become a habit to record smoking status as well. But there was a big variety between these intervention regions. Also, there were regions where we had 0 recordings, but then there were regions where there were more. So, and actually in the intervention regions, a clear improvement happened also in the smoking recordings, or smoking status recordings. The next figure shows what was the prevalence of smoking among those whose smoking status was recorded. Of course, this is not fully reliable when we don't have data from 100% of patients, but it gives you some kind of an understanding that at least 30% of males, these males over 40 years, are smokers in the patient material, which is quite a big prevalence anyway. Among women, the smoking seemed to be not so common, but anyway, these tend to be high-risk individuals, as I will show you later on. These are similar figures for BMI and waist circumference. So in the baseline, quite low values both in intervention areas and very, very low values in control regions in the issue how many times we could find the BMI recorded or waist circumference recorded. And there was clearly significant improvement in intervention areas, how these risk factors were recorded in the post-intervention phase. So remarkable increase in BMI recordings and also in waist circumference recordings. We also had in the protocol or in the training the tools to use audit for alcohol abuse and the European Society of Cardiology score for the total risk assessment. And here you can see the changes in those. In control regions, again, there were no recordings at all, nor on the baseline or after the intervention. But at the baseline audit and risk score audit was recorded for 1% of patients in intervention regions, and it increased up to 15% in follow-up. And the risk score was recorded to about a little bit less than 20% of the patients, and it increased up to 60% during the follow-up, which is of course a major increase. Blood pressure was quite regularly measured both in intervention and control areas for most of the patients, and there didn't happen any major changes during this 1 year follow-up. What was remarkable was that very big percentage of the patients in the patient populations had hypertension. So if you, for example, pay attention to the intervention area women, so 80% of the patients in these patient populations had hypertension diagnosis in their patient files. So it seems that the patient population is quite high-risk individuals who are regularly visiting the services. Or those who are regularly visiting the services are high-risk individuals. We need to a bit figure out this more, how so big percentage of the patients really can have hypertension, but maybe it's that they have more frequent visits than others and they are then more likely to be selected to the sample. Nothing happened in systolic or diastolic blood pressure levels, and they were very similar in intervention and control areas in the beginning and in the end of the intervention. I have to say that I wouldn't have expected any major outcome changes in a 1 or 1.5 year period. So getting that kind of changes in treatment outcomes is quite challenging and doesn't usually happen very quickly in clinical practice. But what I would pay you attention to in these slides is that, however, the mean blood pressure level is quite high. So systolic about 140, diastolic more than 80, and there's clearly place for improvement in this. Fasting glucose measurements significantly improved in the intervention areas. They actually improved a little also in control areas, but there was a bigger increase, significantly bigger increase in intervention areas in fasting glucose measurements. The proportion of those having diabetes diagnosis seemed to be about 10% among males and about 15% of females, which I think it's quite, how do I say, expected. And there happened a small increase in the intervention region in the proportion of those patients who have the diabetes diagnosis recorded. Usually that happens when you start to pay attention. So then you start to detect patients to the treatment. And it doesn't necessarily mean that you have more diabetes patients in the population. It's just that you have detected more patients who have been earlier undiagnosed. But this difference between the intervention and control regions was not statistically significant. So total cholesterol was measured from about 20% in the beginning, and the measurement rates increased significantly in intervention regions. Nothing happened in control regions. And this happened in the overall population, but it also happened among the patients having cardiovascular diseases. And it also happened among patients having diabetes. Statin prescriptions were also looked at, and they kind of didn't happen very much in the intervention regions to the prevalence of cardiovascular disease patients or diabetes patients who we think are high-risk individuals in the prevalence of prescribing statins. But there was some decline seen in the control regions instead. So the risk, what we observed from the data was that the risk assessment and the NCD management processes were already at the beginning quite different in the intervention regions and the control regions. So there seems to be big variety in these processes in primary healthcare in general. Maybe these intervention regions are partly, or among them, there are regions which have already earlier been involved in some similar activities, and that's why the baseline situation was a little bit better, not very much better, however. The risk assessment during this intervention period improved significantly in intervention areas, but many of these risk factors were not recorded at all, or the total risk was not recorded at all in control areas to the patient files. So it doesn't seem to be part of the management at the moment. So NCDs seem to be very common in these patient populations, especially the hypertension levels were very high. And the assessment of biological risk factors, so total cholesterol, fasting glucose, and similar, they also improved significantly in intervention areas, while no improvement was observed in control areas. The prescription of statins improved among CVD patients. Actually, it improved both in intervention and control areas and among women with diabetes in intervention areas. But in this short period follow-up or evaluation, we were not able to see significant changes in treatment outcomes, not at least yet. And for the future, it would be good to, at some point, to repeat similar analysis to see how these improvements in total risk screening and paying attention to these risk factors, does it then finally also affect the treatment outcomes? But there is also an implementation issue. Very easily, when we set up an intervention, and then we try to implement those things in a real-world situation, there happens an implementation gap and kind of a voltage drop, that even we know what to do, then the intention is not as high as we would like it to be. And that needs like a continuous auditing and going back and reinforcing the work what is done. But I will stop here because then Tatiana will tell you more about the qualitative part of this study, and I think it explains a lot some of these observations, what we were able to see from the quantitative data. Thank you.
So we continue immediately to Dr. Tetiana Kyriazova, who's the director. Can we do the questions after both of these? Because they fit together, and one might help explain the other.
Дякую. Так, доброго дня, і я...
Hello, let me continue. I would like to... Yes. So, let me tell you about the qualitative component of this study. We had the purpose to... we had the goal to look not only at the results of what we managed to do, but also to look at the context and the personal component, the factors which also influenced how we could implement in real practice what we taught to the providers. The sampling included 4 types of providers, the managers of the facilities, doctors, nurses, and junior doctors, and so-called felshers. And the managers took part when either they underwent the training personally, or some of their staff. Oh, 5 minutes only? Well, that's... and the doctors, nurses, or the felshers, they all attended the trainings. And we worked with the audience from all the sites, from all 7 regions of the interventions. And we had these groups for regions, for the central region of several oblasts in central Ukraine, for the southern, eastern, and the western bigger region. We have used the thematic analysis to find the factors which could influence the quality of the implementation of these newer approaches. The results are the following. 74 providers took part in the focus groups, 10 men, but the rest were women, and the average age of the providers was about 40 or over 40. And overall, if the doctors and the managers were from big cities, or at least giant cities, then, for example, felshers, naturally they were from rural areas, and nurses came mostly from rayon capitals. and the patients were like 40 to 70, two-thirds of them were married, a third was male, and 5 of them said that they were smoking.
Speaking of positive moments, providers that participated in the training very positively assessed or provided very positive feedback following the training. We really liked that they really focused on prevention component. We had a very friendly atmosphere. They really behaved like peer-to-peer. For example, in Poltava Oblast, one of trainers was a well-known expert in the oblast, a well-recognized specialist, and quite many of participants said that they really took that lady as a great model for action. They also mentioned that the training made them look more carefully into prevention issues, and they said if before they would mostly look into prescribing some pills and drugs, now they switched more to thinking about the facts, about potential ways how to really change the lifestyle and suggest something else to the patient to correct his lifestyle. It was more effective approach when nurses and physicians would work as a team and trained as a team. It was also very important that their managers, healthcare managers, would also be there. Afterwards, they would become more supportive to implementation of these new approaches and further monitoring. Speaking of clinical practice impact, as I mentioned, a lot of the main focus was on prevention, and they also mentioned that early diagnostics and preventive activities have improved, as well as case finding, both true for hypertension and diabetes. The score tool, the score table was very supportive, very good feedback we got from our participants on that, and they said it was very easy really to persuade the patient in these or that issues. When you have a table and you show it, demonstrate to the patient, like if you switch to the red zone, to the gray zone, then the quality of life will be improved. Another point is that many people mentioned that patients started to visit doctors more often because they like the idea that you can be tested for cholesterol, for glucose in one place, and it made really patients to be more interested in regular visits to the clinics. The patients said that really it is true that the accessibility has improved in terms of accessibility to testing, and what they also liked is that they were counseled on potential ways to correct their lifestyle. And one of the patients mentioned, now I feel that the doctor is very much motivated and interested in the fact that I become healthy. Speaking of impact on clinical practice, another important aspect was that nurses and fellows really started to feel more confident when talking to a patient, and we will discuss it a bit later. And these are a group of health providers who usually consider themselves to be a second level of importance, so to say. They're not so important, they think, in terms of services provision, because they think they should be the task of a doctor really to do the counseling, and their role would be like very low and really not very important. But after the training, both the nurses and the fellows underlined that they felt that as of now they feel that their level of knowledge has improved, and now they're capable of providing information to a patient which they do not simply collect or find on the internet, but they have evidence-based data at their disposal, and that was provided to them by the Ministry of Health. That significantly improved their level of self-confidence. And they also mentioned that this was one of the first intermediate results, but in some oblasts they also reported about the primary findings and outcomes regarding the wider access to services provision. It led to a higher level of finding of diabetes and hypertension cases compared to the first quarter of 2017. Apart from those quite positive moments, we also found we came across a large number of barriers and challenges while implementing the project. We also could observe significant differences among institutions and oblasts, and we can see it in the project results. The main barriers that people complained about was the limitation of time for one patient and the excessive overload of nurses. Limited time is 12 to 15 minutes per patient. Majority of providers mentioned that they got back from the training very much motivated, and they started really to implement what they were taught. And then in about half a year period of time after the training, they kind of that spark kind of went down because of too much paperwork, as they said. And they say it in Russian, they say like, I have to do lots of handwriting. So lots of paperwork and lack of time, these were the reasons that really prevented people from doing what they tried to do. And definitely when the patient enters the room, before talking about his lifestyle, you need to you need to find some mutual contact, some personal contact, and then you build trust, and then the person definitely can tell you everything. Excessive workload of nurses, you can see it all on the slide. I'm not going to enumerate everything, but both the medical doctors and nurses mentioned that the nurses are very busy. They have lots of different functions and tasks. Quite often they stay after the working hours really to finish their paperwork. Sometimes they can go out to the houses of their patients. And unfortunately, the workload has only doubled when they introduced the electronic documentation, because unfortunately all of them mentioned that no one stopped the use of paper-based documents. This is sad, this is funny in a way, but the nurses mentioned I have actually to spend a couple of hours every day really to copy this electronic data to the paper-based documents. And the authorities say, usually when we ask about that, they say like, what if a computer goes down? What if there is a failure? And no one no one ever issued a decree to stop doing that. It was already mentioned that the motivational interview was in place, but only by few people. Only a couple of people mentioned that. Majority of people stopped doing that. They didn't have proper skills. Lack of confidence was one of the reasons to that. Lack of confidence in discussing some sensitive issues like consumption of alcohol. And almost no one reported about the fact that they make use of this audit questionnaire or audit survey. They said people simply laugh at those questions. They do not feel very comfortable about that. And definitely this is a rural area. Everybody knows who smokes, who consumes alcohol. And if they don't, usually people hide it in such a way that you will never be told about. So nurses complained that they have to do the measurements, and still after that they usually listen to the doctor, not to the nurse. This is what they complained about. Speaking of equipment available in the healthcare facilities, it's like they are quite different, I would say. One of the representatives said, like, we have everything available, you just need to have your will to do it. Others would say, well, I have some pediatric scales only, I have only the tape, and that's it. The others say, we have only the BP measuring device. And I remember our work with focus groups, and one of the patients, when I asked him, like, what does a doctor usually use during a visit, he said a phonoendoscope, a BP measuring device that I usually see, and a kind of a holy picture, the holy icon on the wall. This is what they use during the patient visits. Speaking of challenges and barriers, again, limited access to examinations at rural health posts. What they complained about, as I mentioned already, they are not very well equipped often. And one of the felchers mentioned, well, you know, when I came to work there in 1988, I still have the same equipment there. The same scales, the same tapes, etc. And she said, I received the cardiography device, but it is not operational. And they have to refer patients to go to another settlement, something like 30-40 kilometers away. Definitely I can find you with more, I can find more examples like that, both positive and negative. But these are the most interesting cases, so to say. Improper conditions of work in rural health posts are quite often the case. Definitely some people were satisfied with their working conditions, but many of them mentioned actually these working conditions are really inappropriate. And they would say, we don't have any nurses positions, we don't have any cleaners position, and the felcher is the only person there, and sometimes they have to provide service to about 2,000 people in the area. And some people said, like, well, some repair needs to be done, because during the winter time I have to wear some outer clothes with me inside, and if a patient presents and you want to do some cardiography or cardiogram, you cannot ask a person really to take his or her clothes off, because it's too cold. And that definitely prevents rural population from getting high-quality medical services. And the final two slides about recommendations. For the next trainings, it is recommended really to invite the heads of facilities, healthcare facilities, or chief physicians, or managers actually, as well as we need to engage the team of a doctor and a nurse. It is very nice when you train physicians in the first wave, so to say, then they would really take the idea of selecting participants more carefully, because sometimes we would hear like 1 out of 24 or 3 nurses out of 18 were trained. It is very good idea actually to develop the training agenda appropriately. Definitely we need to make sure that training is I didn't mention that actually, that majority of nurses and felchers mentioned that that was their first training in life. Some people have been working since 1985. We need to focus more on practical sessions, especially in terms of motivational interview. Without practicing, you lose your skills very quickly. And definitely training nurses some communication skills and overcoming stereotypes. We need definitely to organize additional workshops, I would say, because people were very happy and they thanked us very much for those focus groups. That really became a good chance for them to get together, share their best practices and experiences. They learned how these processes are organized in other regions and other settings. So it would really be a good idea if they have a chance really to exchange exchange their points of view, their experiences. This would support their motivation to change, I guess. Time allocation and staff responsibility should be optimized, really to address excessive workload of nurses. Family doctors in all regions suggested, apart from increase in time per patient up to 25-30 minutes, they also suggested to equip additionally their working rooms and maybe have rooms for doctor help, like pre-medical help, so to say, pre-medical care, so that they would have a chance really to be measured, tested by a nurse, and then they would have a possibility to be counseled by a doctor. And definitely the conditions in the rural health posts need to be addressed to make sure that the people in the rural areas have proper level of quality service provision. And let me finish my presentation with one of the statements from a manager in the eastern region. She said, we are, as well the doctors were all responsible, actually for the first time health of the whole nation is in our hands, and this is not a slogan, that's true, and we are now able to impact the situation if we really want to do that. Thank you very much. Thank you very much everything who participated in data collection.
Thank you very much. We've had 3 presentations which have really illustrated the positive changes that have come about through this project, and that's also down to your hard work in making this happen. And it's also highlighted some of the challenges that remain, and there were a lot of sort of practical issues mentioned in the last presentation which are actually can be fixed, I would think, given some of the things. So really very positive findings. But can we hear from you? What's your impression of the what you've just heard? Does this fit with your own experience? Are there things that you think were misrepresented or which you think need to be added or more emphasized? And are there any questions that you have for any of those 3 presenters? So any comments or questions from the floor? I'll put my glasses on and I can see. Good.
Доброго дня.
Hello, my name is Yevgen Kuzik. He was representing the Antennium Manual on internal diseases. And Mr. Tanner, you remembered the evidence medicine, and this is the evidence-based manual. And I would like to present, this is the first manual, evidence-based manual on internal diseases. Over 600 authors were working on this. It's been published, I think, in the US with McMaster University in Chile, Argentina, and this year it has been translated into Ukrainian. It's very good that now these trainings for the doctors are conducted, and from our side we would be really interested to work on the further publications, because this is the first edition, so maybe there are some flaws in the adaptation, even though the doctors haven't reported it yet, so we are open for cooperation. And if anyone wants to talk about the development of the evidence-based medicine in Ukraine, we are happy to cooperate. And if you're interested, come to me, and in a small presentation I will tell you where it is available. And just please feel free to use it. It's a good resource. It's a good tool to use.
Any comments or questions on the presentations? We know we had somebody who was trying to ask questions.
Шановні колеги, може хтось...
Dear colleagues, if anyone would like to share also their experience, positive and not so positive experience on using these tools that have been presented, or any of the questions on the information, or about the any feedback on how to improve these trainings. Once again, I'm Lyudmila Pillai. I was the regional trainer for Poltava Oblast, and also I was a researcher. So, everything we've heard, the conclusions of Tatiana, This is also what we've had in my research. So slowly, this situation is changing in the regions. And as Tatiana said, well, at least on those trainings that I've conducted, we did try to provide some recommendations on how to change the teamwork approach. For example, these doctors' rooms, we decided, for example, to open them to save time for the nurse and the doctor, so that there would be higher quality care provided to the patients. And of course there are challenges. One of them is, well, there's really not enough time for these preventive consultations. Like yesterday we discussed, for example, doctors who now have 1,800 patients, indeed they're overloaded. It's a lot. And for example, I am in charge of the clinic, and I can't really balance the time of seeing patients in such a way so that doctors would really have better time to talk to patients. And in future, I don't know if we'll be able to make the visit time longer. For example, in winter we had 12 minutes per patient. Now we have an improvement. We have 15 minutes per patient, because we have changed the number of patient visit hours, but still it's a lot. We are thinking how we can influence the psychology of the patients, because patients somehow feel that if they come, they should be seen immediately. Although we have the way to register for the certain time, and we have the also we have the internet registration, so that they could register for the appointment and plan it a little bit more ahead. Also the e-prescriptions, that is very useful, because then the patients would have to come, well, every month or a few months to get a new prescription. Now it's way easier. It's like 40 minutes, I think. And I have a group of patients whom I've been treating for many years, and now if the patient needs the medicine, that the patient just places a phone call, and the nurse, without me seeing the patient, without me wasting time on that, so the nurse does this e-prescription. So we have started improving the techniques, but there is still a lot that has to be done. And, well, there is another thing that is not often mentioned about the accountability. If there's no accountability, you know, any initiative would be in vain. What we said, yeah, it's good that we have the assistance of the World Bank, and in our region the situation is not as bad as in those regions that were not part of this pilot. We have a lot of equipment, a lot of improvements, we do a lot of research, but still, somebody has to do it, somebody has to arrange the nurses in such a way so that every nurse would know how to do all sorts of things. For example, in my clinic and in all the trainings I shared my experience, I have an adequate, well, it might be better of course, but an adequate number of nurses. Now we have 25 staff, 25 people in staff, most of them are nurses, but I have set the task that every nurse must be able to do all the procedures, for example, measuring intraocular pressure, taking blood samples, taking ECG, sending it with the telecard, and all my nurses are able to do all the procedures they need to do to improve the work and to improve the diagnostics. That's true. But of course, a lot of things must be done. Because, accountability is the key. Like every doctor and every nurse report to me daily how many procedures were done, how many inoculations were done. If there's no accountability, then of course the effectiveness goes down. So there should be a leader in the clinic, a manager. That's why you said that we have to start with managers. And the first thing we've started, there's no Ivan Fedorovich present here, but when we came back from the training from Kyiv, we've got together chief physicians, the deputies in the healthcare authority, and we gave them some presentation. Well, it was supposed to be brief, but it took 5 hours to basically teach them what we've learned in Kyiv back then. And it was quite an eye-opener for many. And we've invited the nurses and the doctors for the training and said that the managers of the healthcare facilities should also come for the trainings. That is why we've got some results. Thank you. Thank you for this good comment. Hello. I'm a regional trainer, Galina Dembowska, Vinnytsia region. I also was assessing clinical outcomes and changes in the practices. And I really liked this, because now I see what did we have to pay attention to in the first phase. And with the assistance of the WHO, we managed to achieve the main thing, to switch the primary level to the prevention. And from the beginning, we've been saying that we try to have complicated things like ultrasound, but let's just start with basic measurements like the BMI, the waist circumference. And I see that, it's there as well, it's working. At the primary care in our region, we have, for example, these electronic and the paper sheet for risk factors, excessive weight, hypertension, high total cholesterol. From these, and now we are forming these study groups, 6 to 8 people, because if there are over 8 people, it's more difficult to study. We call it health school. So it's patients education, and we, for example, select patients with obesity so that they could discuss their problem. We organize classes for school children, and also and some facilities provided rooms for these health schools, provided funds for the posters, and now it's basically what they showcase. So it's not something really formal. People get excited with these health schools, and I would like to I'd like to express my gratitude to the WHO, to the Institute for Public Health Policies for doing this. We hope this initiative continues, because there are many other doctors who want to take these trainings. For example, one of the good things was that in health schools we use those healthcare providers who underwent these trainings. And, for example, we already had doctors coming from one village, and they said, well, we didn't attend any of your trainings, but we've heard good things about your health school, and we want to have a health school in our place. And it really changed. It really changed everything we're doing. Thank you. Diana Kowalska from Lviv, a regional trainer and also a practicing family doctor. I would like to support everyone and to say thanks for this huge work we're doing. And she agrees with all this, and indeed 15 minutes per per visit. It's really a little. And we have online prescription system. And indeed, sometimes the week schedule is full. If some doctor is very active, if there are a lot of patients, and of course it is really not enough time. That is why in our clinic we have a nurse coming in, and if the patient needs an ECG done, the nurse does the ECG. If the glucose needs to be measured, the nurse does the measurement. But the nurse inputs all the informations in the database. The nurse also issues an e-prescription, and the nurse also does the paperwork for these declarations, because the doctor needs to talk to the patient, needs to figure out the condition, provide all the interventions, and there's not enough time. So I think we need to have some intervention so that the doctor would choose the time for the visit. I know that it should be possible. Perhaps maybe when the patient is making an appointment, they are asking, are you here to just get a new prescription for a chronic disease, or get a certificate? But if it's like an initial visit and the patient wants to really figure out to find some answer and to have more attention, then there should be probably a longer visit, definitely, because otherwise people actually were people were very happy with the trainings initially, but now they just are not able to use it all. They are not able to implement this all because they don't have time, even though Order 504 says that the patients, that the doctor's responsibility is to manage the patients with NCDs, more or less in the context of the trainings. This is one of the main tasks. But also we have to plan inoculations. We have to follow up with the children. If it's a family coming to visit a doctor, if it's like a grandmother, a mother, and a child, it really is a lot. So maybe on some higher level this could be sorted out. Another thing about this e-prescription, we are seeing this problem that now this e-prescription can be made by only a doctor who signed the declaration with the patient. For example, now I am here in Kyiv at the conference. In these 2 days, my patients might need a prescription, and my nurse, who has no right to issue prescription, even though she's doing it. But anyway, another thing, when the patient comes, basically the answer is, but sign a different declaration with a different doctor. So for example, if a doctor goes on sick leave, they might lose like a third of their patient in a few weeks.
So may I make a short comment? There has been discussion today related to like good indicators of quality of care. There has been lots of discussion related to there's not enough resources, there's not enough time. And then there was in Tatiana's presentation observations that some professionals are not recording or assessing things because they think they know, and there's no need to then record it because they know that the patient is a smoker or is not a smoker. But however, if you are not recording the things to the patient files, somebody else won't know. You can't derive any proper quality indicators if you don't have the data there. And if you can't derive proper quality indicators, you can't adjust the treatment processes according to them. We tend to have the practice that we have current care guidelines or clinical guidelines, and we give the same treatment to everyone, whether they need it or not. And it's unnecessary to follow patients who are in good control every 3 months. You can follow them once a year or even once in 2 years if they are already in good control. it's better to pay attention to those who really need the follow-up, who really need the intensification of the treatment. And if you have good data in your patient records, and if you can then derive these quality of care indicators, you can do patient segmentation and find those patients who need more follow-up and more treatment, and then do rest with the ones who are already in a good control. So these all things are going hand in hand. Have good data to be able to follow the patient, the performance through the data, to be able to deliver or to adjust your processes according to what you find from the data, and then you can really do the sharing between the nurses and doctors, who is doing and what, whose competence we need in each of these stages and steps.
Anastasia?
Я хочу зробити
I would like also to add to what Tina said. When we talk about the indicators, today indeed there was a training of an indicator proposed by World Bank, and now there's been the discussion on how this tool can be switched to Oblast. In our trainings we have remembered quality indicators. But what we did as part of our project, we understood that the information on this it's not enough for the primary level. We understood that further trainings must be organized for the managers. And in particular, we must explain that the list of qualitative indicators has to be probably endorsed by the National Health Service. Because now this work so far it was not among the first priorities. There was no need, so there was need for, first of all, to have the first phase of the reform, to sign the declarations, but now we can talk about improving the quality of the care provided. And the monitoring of these indicators is the thing to improve the quality. So, we understand that in our training, for us, we didn't allocate enough time for this. We said that this is important, but further, this is what we have to do. We need to get the data to make it clear and to make it also uniformly understood by everyone, so that everyone could see where we're going, what are the priorities, and what are the priority indicators for NCDs at primary level.
We need to move towards the last part of the session, and there's opportunity to speak and discuss again. If I just summarize some of what I've heard so far, sort of through this session, evidence-based approaches exist for changing clinical practice, and we have tried to use those in these different projects within Ukraine, and we've actually demonstrated that improvements. We've demonstrated changes in the training processes, in the recording of the information. There's even been comments around improvements in patient satisfaction. For monitoring and evaluation, data is important, but it's also really important for clinical practice, so that we are managing patients according to their need. Organisation of care is critical. At that point we mentioned earlier about the distribution of tasks between doctors and nurses. And we've also highlighted some really practical barriers that need to be overcome, which relate to time or equipment, for example. And then I've also taken from this session that there is a lot of willingness from the different broader partners involved, the WHO, the Swiss and World Bank, to continue to work together in support. But we also see leaders from amongst you, institutions, family doctors, nurses, managers, felchers, who are enthusiastic to continue to work on this and make the changes. And I like very much Tatiana's last quote around the health of Ukraine is in our hands, and we've managed to switch primary healthcare towards prevention, which has been the purpose of this. So those are my kind of concluding comments so far from this session. But what we're going to do now is look at recommendations for further priority actions in Ukraine. And to start our thinking, Professor Kimion is going to do a short presentation, and then again we'll have a round of discussion. We have to finish at 12:30 for sure, because everyone will come back in this room, and then we will start the final plenary.
Шановні колеги, сьогодні вже ви
Dear colleagues, you have already heard today's recommendations today. You have heard these recommendations from each other. You know it based on your personal experience. So what we actually need to do as really primary priorities in order to improve the situation in the sites, in the healthcare settings. So for the purpose of discussion, just like Jill did it right now, in very brief statements, just in very wide brushes, so to say, let me enumerate a couple of issues which are still there. Being a family doctor, what I can tell you, we need to keep in mind that the responsibility for prevention and health is carried out by all levels of social public life, starting from the president and high-level politicians, the community in general, and the community in the site where you work. They all are responsible for health of our community members. If the community doesn't care about pollution of rivers, if they do not have safe food, if moonshine production is really blossoming, a family physician can hardly fight it all himself. But the family doctor needs to remember that he or she is actually a leader in organizing these safe and healthy practices and teaching the community those healthy approaches. Now we have a new profession in Ukraine, a public health doctor, basically, and the family physician is supposed really to have good contacts with the organization working in the field of public health in their area. There must be a unit or a department for NCDs. They are supposed really to assist us in organizing proper activities really to cope with that problem. Education, we already talked about that. And what is actually the role from our side? We are the specialists in primary healthcare. This is why we work at the PhD level. And the main component of PhD is by default prevention. We are the experts in prevention, and we must realize that the most important activities for prevention should be carried out in our outpatient clinic, because this is the point where the first contact happens with the patient, and this is the place where you are supposed to perform this kind of activities. Lyudmila mentioned there is no activity without proper recording. Audit system must be there. Don't think it shall be an audit from the World Bank or some other global partners. It can be some internal, local audit. You can just get together once a month, discuss your parameters and indicators, discuss what you want to achieve, and go on doing that. This is an audit as well. Why we need that? Because our global systemic aim is definitely to expand lifespan, improve quality of life by means of stopping the spreading of preventable conditions and reducing the burden of NCDs. Definitely, I'm not going to read everything from this slide, but what we currently lack, we definitely lack that regulatory framework and tools. Give us tools into the hands of a family doctor so that a doctor within the range of those 15 minutes be able really to perform his role. Give him a kind of card or something like that, electronic card, when the patient presents to a doctor once a year, for example, and it prompts to a doctor like measure BP, ask for these and do that. So give us tools to do the job. Teach the patients really how to work online with the School of Patient. A great example from School of Health. Give a chance to patients really to learn about that and do that. I saw these schools of health in Dnipropetrovsk, for example, and it would indicate very clearly, like every second Wednesday, for example, of the month, there is a special meeting with the overweight patients. It should not be the task of a doctor specifically. It might be a nurse or a volunteer who is well trained on some physical fitness activities or something else, for example. But this is the family doctor who needs really to be the leader of this process and needs to have access to the resources of the community. We need to teach the families that this is the responsibility of the family really to keep the proper health of all family members. We already talked about technologies. What I really liked today, and let me reiterate that, all the team members must learn together as a team, and they need to have a chance really to repeat those training cycles, to update themselves and to refresh their knowledge. We should train not only physicians, we should also teach them how to delegate authority to nurses, and also this is true for administrators. And it has already been mentioned by our colleagues, and this is the right way. This is the right way to go, by the way. And for us, this is a good issue, and I know that the educators are working upon that. This is the establishment of a open, wide educational platform for students, doctors, nurses, and other team members, so that everyone could be able to find a good place, a good possibility really to implement that into their daily activity, and everyone would really have a chance to master those competencies and skills which are being shared by the WHO experts and colleagues. The problem here is that it needs to be done very quickly and simultaneous with many other activities. Why international donors and experts cooperate with us so actively? This is because we have very critically low parameters and figures. And you remember our colleagues said that the European region really needs to speed up with some activities because they cannot achieve those goals, sustainable development goals, by 2030. Ukraine has to speed up even more really to achieve that, and we definitely need to master these skills and activities like right now simultaneously with other activities. We're definitely grateful to WHO experts and other colleagues whose tools we're using very widely. Thank you very much for providing us a chance to learn from you. But we talked about evidence-based medicine. To make it really be used in the clinical practice, it is necessary, as Jill mentioned, for a doctor to have a very brief, clear and concise manual for activities. And sorry, but it cannot be in English. And the Minister of Health should not say to us, like, well, you being the physicians can make use in your practice of any other clinical guidelines, and you can use any English document for this purpose, and you can share it with the patient. Sorry, guys, but we're talking about Ukraine. It needs to be a clear, accessible, brief, concise, understandable, unambiguous document. And it would really be even a better idea when you have it on the e-database, electronic database. If you use some ICPC code, immediately you get a pop-up window that provides you with some idea where to go. Who of you makes use of electronic version of ICPC? Are there any people? Great, great. But still, majority of us still use the paper-based documents. It is quite a complicated way to go, by the way. It puts on additional barriers. If we improve our work, it will become much easier for us. And I do really hope it will happen very soon. then it will really enable us really to perform very quick reporting and recording, and then the deputy chief physician, for example, can go into on the database and can see immediately what is the number of prescriptions, what is the levels of cholesterol in the target groups, and then you immediately can have the quality indicators for your preventive activities. And if they provide you some bonuses to that, then you will be happy absolutely very much with that. Being an educator, being a faculty staff, let me also tell you that we definitely need to improve training in PhD field for doctors at the pre-diploma stage, because as of today a family doctor is really one of the most required professions in Ukraine. We do not have that deficit in any other field of medicine. Each Ukrainian has the right and has the need to have a family doctor, and the deficit is about 30%. In some regions it might reach as high as 60%. So how can you talk about proper work? And until now we do not have a unified training program for family physicians, do not have a standardized curriculum. But we need to train them properly, we need to teach them. We need to teach physicians to work with healthy patients, because we have been telling our physicians for decades how to work with an ill patient. We need to teach them now how to do the same thing, how to prevent the conditions in healthy people. We need to bring that idea to their understanding. We need to support them. And now, as far as we have deficit in human resources, maybe we need to think about reprofiling some other professions into that. Speaking of continuous professional development, I think it includes all types of training, including workshops, seminars, trainings, etc. And definitely you need to ensure that there is a possibility for remote learning, distant learning, electronic-based learning. If it is paid, then it can be paid, and it should definitely be in Ukrainian. A BNG, great project, but it is in English, and that is a significant limitation, I would say. And if a person made a little mistake, even a minor mistake, it might not be very good when that minor mistake would be used in his clinical practice. Now we have a bit of time for a short feedback. So maybe you have some suggestions, suggestions for discussions, or maybe issues, because I'm done actually.
Make recommendations for further. This would help. Asked to make recommendations for further priority actions in Ukraine on NCD interventions in health settings, which we feed back. Listening to you and also with you, in terms of recommendations for further priority actions, I think we need to consolidate what has come out of these projects so far, so we don't lose the learning and improvement that's already happened. There's been a strong emphasis on recording data so that we can demonstrate improvements in quality of care. You've spoken strongly about the importance of education and teaching to make sure that we have health workers who are really equipped with the knowledge, skills and attitudes needed for this work on non-communicable diseases and prevention and management. I can't read my writing. We need to voice about these barriers. So we've highlighted a number of barriers and some of the very difficult circumstances that people are working within, and we need to make sure that the authorities are aware of those to see if any change can be brought about. We need to complete this evaluation and make sure that we communicate the results so it informs change. And I think we need to build on what works well, because we've got so much energy and in the room, and so many people who are enthusiastic, who are champions, who've got good ideas for how they've organised care. And I think having the opportunity, the continuing opportunity to share that information with each other would be good. I know that's something we've done in some of the other countries, that we've regularly brought together the people involved in this works, also in peer-to-peer learning, so that they have an opportunity to share with each other the good practice. So those are some of the things I've heard from what you've said. Any other comments about recommendations for further priority actions?
Що ви думаєте на
What do you think about... Yes, Ms. Ludmila.
Я хочу нагадати
Let me remind
тут присутнім, можливо,
let me remind everyone here. Maybe you don't do it in your oblast, but let me remind you about risk factors. When we started this work in identifying the risk factors, we used the ICD-10 that included those risk factors. So now, on a quarter basis, we analyze by each physician, by each healthcare facility, what is the salt intake, what is the level of physical activity, what is the tobacco use, and that actually stimulates our physicians, first of all, to identify and find these risk factors. And once you asked the patient, like, what is your salt intake, then you are kind of supposed to provide a recommendation if you want it or not, right? Because you have to do it. Actually, you need to look for those risk factors, because there was a decree from the Department of Health that went down to the PHC level. That was one of the first stimulating factors. I'm not sure if everyone has it in their oblasts, but this is a good idea, I guess, that we can go on with. We can do the same for district levels, for local levels, and we can investigate if actually the family physicians do identify those risk factors, if they can impact that. This is a huge amount of work, I'm sure, but that really leads to improvement of the situation, because whether you want it or no, the physicians and nurses are supposed really to do it, even talking about such really easygoing and easy to understand things. I think that kind of work could be easily simplified if we had an electronic-based system that would be available at the level of region. Sorry, no microphone is used. But we do have the electronic system. It's a statistical system based on the ICD-10, and we were the first ones who implemented that back in 2010, I guess, and 2007. Starting from 2007, not a single physician or nurse can imagine their work without a computer. We do not have anything, any kind of paper-based calculations, just as many people still do it. We have an electronic software available. I also have a kind of sub-software or applications available for proper calculations. We also have software for ICPC, which is integrated into our electronic software. Unfortunately, we do not have proper integration with the e-health program, and we are now awaiting for changes. Thank you very much, dear colleagues. By the way, that is a very positive piece of experience we need to share, and we need to talk about. If outpatient clinics are properly equipped, they are properly staffed, they have proper training in the field of IT, then it leads all to a more fruitful work, basically. So this could be a good requirement, let's say, when we speak about the list of equipment, of essential equipment, so to say, in the outpatient clinic, and you cannot sign a contract with the Ukrainian NHS without that. Then we can talk also about the standardized approaches to equipment of a working place of a doctor. It needs to include all the proper equipment that really facilitates the work of a doctor in terms of statistics, recording and reporting, which is both true for the doctor and for the nurse. I think it would be a very topical and relevant activity really to improve the efficiency. Otto?
Thank you. Yeah, to continue to what the colleagues said, I see that they are leaders already, and they would like us all to introduce some administrative mechanisms to support these leaders, to support the trainers who are ready already, so that they could inspire their colleagues. For example, when they talk to practicing doctors, they say that, yeah, I did this and that, I was successful, so the colleagues, they come to me. So this peer education, I think it's a very important component. And just to, like, I've been remembering this example when, well, it was an example from American colleagues. They were wearing the badges and saying, I can help you stop smoking. And they just walk along, for example, the corridor or even in their office. But still, sometimes other doctors see them and come to them for the consultation. This is just a small example of this positive inspiration. And it would be good if these trainers, if those who inspire, would also be somehow supported and promoted. And for example, the Fachstrom test. Well, the nurse can do it, and even the patient can fill it in while they are waiting, or the audit test. While the patient is waiting for the visit, they might also fill in this questionnaire and already, for example, get in this mindset of the conversation with the doctor. So we can also do more patient education. For example, when the American colleagues helped and explained assistance to quit smoking, they said that American patients are expecting the question if they're smoking or not. So it has to be a change in the mindset, and well, the patients also, for example, think that, oh, this doctor is asking this question, so he's using new methods, so it is a good and respectable doctor. That's why it's another reason to spread this.
Thank you. Any more comments?
Ну, я просто хочу.
I would like to say, and we've mentioned this before, but I think this has to be really emphasized as one of the priorities. The priority of changing the education system and the role of nurses, to strengthen the role of nurses, to give more information. For example, from what we've heard from the qualitative research, that for many it was like the first training ever they had. This, I think, has to be changed. Like some time ago, there was a change in the continuous development system for doctors. We know now they can have scores, they can attend conference and get these continuous education points, but for nurses, unfortunately, the system is still old. They can also go for one continuous development course in 5 years, and they always outside of the scope of the trainings aimed to improve patient management at primary level, because everywhere the doctors are invited for the trainings, and we forget about nurses. Well, nurses are a big resource that has a lot of potential, and then together the nurses and the doctors can work more effectively. And this is why I think for the future, the changes of emphasis on the nurses and the change basically in all the framework of documents and what the nurses have to do and don't have to do and how to balance the workload on them, this aspect I think should be emphasized.
Any other comments? Last 1 minute. I've been writing down what you're saying on my phone. I'm sending them to Anastasia, and she's trying to put them on the slide. So we're trying to be as efficient as we can, so it is ready for the next session. Yeah, then you'll have an opportunity to also comment on the slides that she puts up. Any other final comments? Okay. So shall we close? Congratulations on what you have achieved. It's fantastic to get to the end of the 4 or 5 years and to see what's happened and to still see enthusiasts in the room and to have learnt from your experience. I wonder if we have time for a photograph, possibly, of us all together. But I don't know who could. I'm looking again at Anastasia because she tells me what to do. Is it possible we could just stand here? We move the tables for a second, or we stand and we bring you all together? Because some of you I haven't seen since we were all together for the training, and I would certainly like to have a memento of us all together, if that's possible. And then we reconvene at 12:45 in this room, but perhaps we could take a photograph before people come in. Thank you very much for a great session.
Inaudible.
And things.